When I was asked to speak today, I had a chat with the organisers of the conference about what I might speak about. And we ended up deciding, or my takeaway from the discussion was that I would speak about, to sort of weave through our different studies in public health and oral health, community-based research studies, and just draw from that tales of food, migration and teeth. That was my thought. Could we bring the slides up, please? Thank you. So this is my idea of what I was talking about, and just sort of in the busyness of our everyday lives, pulling the slides together. And then Wednesday night, I thought I'll just have a look online and see what's on the program. And this was the title that was given for my presentation today. It's a little bit different. It was the imperative for integrating oral health with general health, picture of our nation's health and the need to work together. And I thought, it's just a little bit more ambitious than what I had planned. So I'm very grateful to Jorg and others today for giving you a much better picture of the nation's health than I ever could have done. And I will happily contribute to others' presentations about the interplay between general health and oral health, and absolutely the need to work together. So I will draw from just 4 studies that I've been involved with over the past long time. The first being Fun and Healthy in Moorland, which was a cluster randomised control trial in schools in the Moorland area, addressing child obesity prevention and promoting health. And also Teeth Tales, which Joan mentioned earlier, which was a child oral health study addressing socio-cultural differences, and that ended up with a matched comparison trial. And then, of course, the 2 birth cohort studies that have been operating throughout Victoria, VicGen and Splash. I don't intend to give you scientific details. As I said, I'll be just having a chat. So the first study I mentioned, Fun and Healthy in Moorland, we're working in partnership with Mary Health and had fantastic support from Moorland local government and obviously the schools that we were working with. So there were 23 schools involved in this study. And although it was a randomised control trial, we didn't have a set intervention. Instead, we had set parameters. And we said to them, we will support you, but what we would like you to do is to introduce strategies that will increase physical activity, promote healthy eating, promote well-being, and work across the school. So all genders, all school levels, ongoing programs. It's fairly easy. And this is what started to come together about 2 years into the process. Now, if you're looking at this map, the really small writing, it means that it's only happened at 1 school, and the bigger the writing, the more schools introduce that strategy, because our approach was customised to each school environment. Obviously, we've segmented it there into strategies addressing healthy eating, physical activity, well-being, and general health promotion. And the inner circle are those first things that get off the ground that really are just about raising awareness. So it's the school assembly where the kids dress up like a piece of fruit. And it's really cute, but it's not going to change anything. But it's a great precursor to actually meaningful change. So the second ring is that meaningful change. It's ongoing changes in the school environment, whether it was the physical environment, the curriculum, or other sorts of programs. And then the next circle was where families got involved, and the outer circle was where community got involved. So we kept monitoring what was happening to make sure that the whole program was moving in the direction it should. And at 4 years, or 3.5 to 4 years, this is what we were seeing across all the schools. So you can see that there was an enormous amount that was achieved, but it took a long time. And we often don't allow for that, especially in our sort of limited funding context that we're in. You can also see, perhaps more at the first stage, that a lot of the effort tended to be directed in healthy eating. In some ways, it's an easier place to start. And certainly one of the more popular initiatives was just a drink water policy at the schools. and a lot of activity around healthy eating and very creative ways of addressing these issues. And what I found interesting was that sometimes they stepped away from the health message altogether. And one of the most successful strategies in a number of the schools was the nude food days. And I don't know if you've heard of nude food days. Some of you will have, yeah. And they were actually introducing it as part of an environmental process in the school. It was separate to the Fun and Healthy in Moorland, and it was to reduce waste in the school ground. And the idea is that the children, whatever they bring to school in their lunchbox, has no packaging. And so inevitably, not only does it reduce packaging, but it tends to steer families towards fresh food. And so it can have those added benefits. Of course, you do get the odd parent who will empty a packet of twisties into the lunchbox, but perhaps we won't go there. And so we learnt a lot about how to make changes in schools and what drove decision-making in families around healthy eating for children. And we did find that there were some cultural factors involved. And for families that had come from countries where the water was not safe to drink, they'd often arrive in Australia and nobody really thought to mention to them that you can drink the water here. And so they're buying soft drink for the family as just part of their normal everyday diet without being aware that it's not healthy. And similarly, if they've come from a famine-affected country, there's a real attraction of foods that are high in fat and sugar, and often not aware that these are not everyday foods. They see people in public eating them, not necessarily aware that it's not part of the family diet. And of course, if your family starts to become overweight, you may have come from a country where that's a good sign. That means you're healthy and wealthy. So, what we did find in these health promotion activities was you can't always assume that we've got the same starting point. And that early formative research is a really important part of the process. So we did find in that study that in those areas that were highly culturally diverse, there was a higher rate of overweight and obesity in the children. As Jorg mentioned, I think this morning, we would see at the population level about 1 in 4 children being overweight or obese. In these communities, it was about 1 in 3. And we were finding a relationship with ethnicity in our research. But we did find that it is possible, we demonstrated that it was possible to make health promoting changes in the school environment and to have subsequent improvements in healthy eating among the children in the schools. But as I said, it takes time, it takes leadership from the school principals, and the partnerships were a really important part of it. And in fact, this was such a lovely experience of a collaborative project for me, because what we did was we employed project staff across 2 organisations. So we had some project staff employed by the University of Melbourne and some by Mary Health, and we were co-located. We sat together in offices for 2 or 3 days a week, so that you truly drew on the resources and the expertise of both organisations. And it was in one of those meetings of the health promotion team and the oral health promotion worker reporting to the team about these amazing stories she was hearing about how people from other cultures are taking care of their teeth and different beliefs around oral health. And they said, "Have you heard of the Miswak?" And we were like, "Well, what's the Miswak?" How many people here would be familiar with the role of the Miswak? Okay, so I'll give you my clumsy explanation, and please, for those who cringe, I apologise. But the Miswak is actually a stick that comes off a tree, and it's used by many groups around the world as a means of cleaning teeth. It's a soft wood, and you chew on the end until you get a frayed end, and you use it to clean your teeth. But it's also connected with religious and cultural customs. So there's a lot of you need a lot of understanding about how that's used. And so the next step was we went and had a chat to the dental staff and said, "Have you heard about this?" And there were some other practices as well. And they said, "Oh, no, we're not really aware of that." But certainly we are finding among the families coming in that we're not seeing a lot of the children coming from these different migrant groups, but when they do come, they have very high treatment needs. And of course, the researchers in the room went, well, there's a study that we need to take on. Let's explore the socio-cultural differences in child oral health. And so began Teeth Tales, with many of the same partners from Fun and Healthy in Moorland. We just added more, basically. And you'll see that North Richmond, yes, they are there. I thought for one terrible moment, Martin, that you weren't up on my slide. Yeah, I know. Most of these have been superseded by new logos, but these were the originals. So we started Teeth Tales, and it ended up being a 9-year study of different stages. We did some exploratory research, then we ran a trial, and we found that those things that had come up with Fun and Healthy in Moorland around drinking water and foods that were high in fat and sugar were coming up again in relation to this study. And also concerns for some communities around using toothpaste because they thought with the gelatin in it, it might not be halal. And also, many parents not actually worried about children's teeth because they fall out anyway. And so why do we need to worry? So there clearly was a need to do something. And the families were saying to us that they were really not quite clear about what services were available to them and whether they were costly, whether they would have to wait a long time. There was a lot of uncertainty. And so we developed an intervention for Teeth Tales, which was about what is a model that you could use in the community sector that is effective and is reasonably costed as well. And it involved 3 components. One was working at an organisational level to see if they could be as accessible as possible to different groups who arrive in Australia and are not familiar with the health systems. The other was to go out into the community and to have peer-led oral health education programs happening so that there is sharing of messages about different cultural practices. And finally, a research and evaluation component so we could really understand what was happening and what was making a difference. And part of that research process was an initial oral health screening out in the community. And we had our cultural partners were incredibly influential for us. They were our recruiters. They brought the families in, and we ended up screening over 600 children from Iraqi, Lebanese and Pakistani backgrounds. But this would never have happened if we hadn't overcome one barrier. We were all ready to go, and the dental services manager said to me, well, I don't know if we can do these screenings out in the community because we don't know how to code it. We don't know how to claim it as a service. And at first, my inclination is, we come on, this is important. But of course, that's a very real issue. We're all running on a shoestring. If you can't code it, you don't get money for it, so you can't do it. So luckily, I was aware that Michael Smith in Barwon had been doing this already for his research and he'd managed to claim it. So I gave him a ring. I said, Michael, would you mind? He's been a long collaborator of ours. Would you mind having a chat to our dental services manager at Mary Health and telling us how you did it? And he did it legitimately. I'm not saying he cooked the books. I don't know if Deb's still here, but I promise. And so he made that call, and that was the barrier removed. It wasn't just that problem was solved. The whole demeanour of our dental services partners changed in that instant, and it was all systems go. And so it was a fabulous study. The oral health education programs were conducted in the community setting by peers from the same cultural and linguistic background. So they certainly delivered the Dental Health Services Victoria key messages of eat well, drink well, clean well and stay well, but did it in a context where it was discussed in relation to what their practices were, what they'd grown up with, what they were used to. And you can see that for the last session, the little boy in the chair, they brought them back to the clinical context. So that the introduction, the connection is made in the community, then they brought them in to say, this is how it operates, this is how the appointment system works, and worked through some of those issues. At the same time, we were running this cultural competence review process in the organisations, and we're able to show improvement in all the participating organisations. Not that anyone got to nirvana in terms of the perfect organisation, because really we can never achieve that. It is about endeavouring to constantly improve. And so what we found was that in this community, about a third of the children had some form of caries, and in fact that's likely to be an underestimate because we were using a modified screening process because it was in the community, and that is likely to be a little bit less than what you would normally see. We found that 88% of the children had never visited the dentist, and that the risk factors for caries was actually not ethnicity in this group, it was length of time in Australia. So that first 5 years was when there was the greatest level of risk. Consumption of sweet drinks came through really strongly as a clear predictor, and so we need to be really mindful of that. And the sweet drinks was a wide range, and it included adding sugar to water, which was a practice that we were finding in some families. We did manage to improve child oral hygiene for those who did the education program and increase parent knowledge of how to brush teeth. But, you know, it was actually hard to get families in to do the sessions. When they came, they loved them, but we all have competing commitments, and so that was challenging. So we generated a number of different outcomes for use by our different partners. So this was a community report. We also, of course, you know, had the outcomes for the families were the screenings and the oral health education. The cultural competence review manual and resources are now being provided by the Centre for Culture, Ethnicity and Health, and they're continuing to adapt those. And the child oral health education manual is available through Mary Health. We continue to work with Dental Health Services Victoria to feed the research results into their planning. And of course, we have been contributing to the evidence base through academic papers and presentations. But we all learnt a lot from the process, and we've all continued to work with each other. We literally say, what can we do together next? Because it's incredible when you bring that mix of expertise into a room, what you can achieve together. And we've actually embarked with many of the partners on that study on a refugee social inclusion project, which is around sports participation. And we're also continuing to work with North Richmond on research that they're doing, and we've just heard working with Anna, which is a lovely new project for us. And I wanted to tell you as well about the birth cohort studies that we have going on. How much time have I got left, Ruth? Have you got
Rachel's, I've handed it to Rachel. Rachel's doing the rest of the day.
Oh, settle in, everybody. So our 2 birth cohort studies also involve many of the partners on the other studies. And one is called VicGen and the other is called Splash. I'm not going to actually say a lot about them, but what is coming through really strongly is more information about infant diets. There's not been a lot available about what the really young children being first introduced to solids, what's part of their daily diet. And so we've been teasing that out. And to be honest with you, it's a little disturbing. The unhealthy foods, you know, this is the age where I would have thought it's the easiest time to control a child's diet. And yet they're being introduced to unhealthy foods and even soft drink from the age of 12 months. And that's really concerning, obviously, and certainly, particularly with soft drink consumption, we're seeing rapid progression of decay. But we're also seeing, for those who are not drinking soft drink, that early lesions can actually be reversed with good oral health care. And I certainly wasn't aware of that before, and I don't think that that's widely apparent in the literature. So that's actually exciting. There's a lot we can do in this group. That's what it's telling me. Sorry. I can only hope that's mocked up. So I guess just in terms of kicking off the discussion, this is my contribution. The soft drinks and other non-core foods in infant diets, is it the new social norm? We didn't see a social gradient in that. That's what worries me, where we do see it elsewhere. So it does suggest that it's become accepted that that's normal, or it's about convenience, or something is going on. We can see, we talked earlier a lot about the alignment between oral health and diabetes and other health conditions. Obviously, the risk factors are common for overweight and obesity as well. So what can we do? How does that present an opportunity for us? And do we need to do things differently to account for those cultural influences? But most importantly, how do we build partnerships? Because together we can achieve so much more than we can alone. Thank you.